Sergeant, breast and general sergeant. I started my education in Greece. I progressed in USA, France, and in the last 11 years I work and live in London. I have the privilege to work also with Mr. Japan, and I'm very happy to be here tonight here with you. I'm very impressed to see the audience, which honestly you're so interested to hear and take every word we say to you here. And these faces I see here tonight, I see many times in the clinic. As you will see in my slides, I hope I will not get you tired, because you already hear quite a lot of information. But I hope you'll find them useful as well. Επίσης, μπορώ να σας μιλήσω και στα ελληνικά. Κάθε ερώτηση που θα προκύψει στα ελληνικά είμαι διάθετη να σας την απαντήσω. I'm very happy to answer all your questions in Greek as well. So do not hesitate to raise your questions, and I think this is probably the evening for you to raise more questions, and if you tell me stop to give you these questions, I'll be more than happy, because I think this is for you tonight. You hear a lot of things we talk to you, but there are a lot of questions you raise, and a lot of information also the internet gives you, which sometimes is quite misleading. So to have a guide on this information is very important. Now, if we go back to slides, this is the simple anatomy of your breast. Breast is a gland. Some books, they say it's a modified salivary gland. So it produces some fluid, which is the milk, and it's useful for the lactation, and not only. Now, the next slide, please. Now, one most simple question you might hear: which is the breast that will develop most cancer? The answer is the left. Now, if you ask me why, unfortunately, even we've done thousands and thousands of studies, we will not be able to precisely give you an answer to that. But statistics show a high incidence of breast cancer, early and invasive, on the left breast. Next slide, please. Now, if we take the breast and divide anatomically and topographically, you will see that the highest rates of breast cancer we see in the area which is close to the axilla. It's in both early and invasive cancers. And it's one way that a lot of cancer are detected clinically is by finding a lump on that area or under the armpit. Next slide, please. Again, the same slide shows the incidence of the early cancers in that topographic area. It's the outer upper towards axilla area of your breast. Next slide, please. Now, I decided to bring you a little bit of history in the breast cancer. And since I'm a Greek and my father is Hippocrates, I would very like to underline you that cancer is described actually in Hippocrates' time. In Egypt, in 1600 before Christ, there were described 8 cases. And additional to disease is probably more involved than just to be locally in the breast. So they had an idea, probably it's not only localized disease, but also systemic disease. What that means? That is spread in other parts of the body. Now, the treatment, the surgical treatment of mastectomy, it was known and referred in 504 year. It's the year of Roman and Byzantine time, Theodora, wife of Justinian. The Greeks you probably know about them. Theodora and Justinianos. So Theodora actually died of breast cancer at age 48 years old. And her doctor at the time advised her to go for a mastectomy. So they had an idea to what it could be a treatment, local treatment at that time. Of course, she did not have the treatment of mastectomy. She died in June in that year at age of 48 years old. Οι Έλληνες την εορτάζουν, την Θεοδώρα και τον Ιουστινιανό. The Greeks we celebrate in our religion, Theodora and Justinian. Now I go a little bit far, and I come to the year 1674-1750. This gentleman, Jean-Louis Petit, is a French doctor who actually found that the breast cancer is spread beyond the breast and goes to the lymph nodes under the armpit, under the axilla. And after him, it was later in Scotland, somebody called Benjamin Petit, who in year 1749, I think, he also had the same concept. So what they've done, they started operating on the breast, and at the same time, they were clearing the lymph nodes in the area. But also, they were doing extra surgery, clearing the whole muscle sitting where the breast was sitting on. Now, this operation later on in 1882 was taken by an American doctor who was a great surgeon, and his name is William Stewart Halstead. His operation was left for us doctors for many years later. Next slide, please. He applied the radical mastectomy, that was the name of operation, and his name, this operation holds his name. The radical mastectomy for USA, United States of America, was applied up to the year 1970. Now, the Europeans had the concept to preserve the breast and don't do radical operation a little bit early. And why is that? Because we had more scientists in Europe, we had women scientists as well, and the interest was higher. Also, in the States, they had very strict rules with the insurances, so it was also a money thing that kept the radical mastectomy a little bit later, longer in the United States. So, as you can see, the surgery has really started to be questioned and improved since 1950s, where we've done preserving breast conserving surgery, as we call it. As you can see, the breast cancer staging, which divides staging shows the severity and the aggressiveness of the disease. It started to be concepted in 1992 and 1930s. Now, well enough, in 1970, we very well named breast cancer as a systemic disease. So we clearly know now that the breast cancer does not involve only the breast, but something more than that we should consider. It's a disease that can be spread in other places in the body. It's well established also the breast conserving surgery. The treatments of breast cancer, since we have the concept of the systemic disease, that means we need to treat, to do something more than surgery. It started after Second World War. Next slide, please. Now, a very famous scientist, Marie Curie, who took the Nobel Prize in 1903, she said, "Nothing in life is to be feared. It is only to be understood." And this is where I like to stay with you, because there is a lot of panic regarding the word cancer. Every one of you in the clinic stay so silent, the same as you are with the faces you are now, to listen to us and ready to see if we say that word to you. But it is clear, and tonight we, as Mr. Chaffet and me, we like to reassure you, although the debates, the recent debates, there are progress in breast cancer and there are treatments, and this is a disease now that is treatable. Even the incidence has not changed. And it's treatable. Surgically, we have precise operations and we preserve the breast. We have an enormous number of trials go on with different drugs that we apply. And not only that, we've got the biological studies. And what does it mean, biological studies? It means now that we look more than just the type of cancer that the women carry. We look into the genes to see what was that is different in this tissue that we have. And that helps to organize more treatments. And as we call it, target treatments. And some of you, if you hear about it, is the Herceptin for the HER2 receptors. Next slide, please. Now, it is a disease that does not interest only you, it's worldwide concern. And it's actually interesting, if you ever go in October in USA, it's very, very interesting to see that every single shop has that ribbon on, and every single shop offers part of the earnings to the research for trials for breast cancer, but also at the same time for other cancer. It is a work that we still need to do, a lot of it. Next slide, please. In the European Union, the previous slide referred to European Union. It was probably some of you saw it in some books. It was published in 2003. Now, we approximately know in the European Union that every 2.5 minutes a woman is diagnosed of breast cancer. Every 7.5 minutes a woman dies of breast cancer. Even I reassure you that we indeed have progressed the treatment. Next slide, please. I'll bring you now to the UK, some facts. You hear some of them with Mr. Jaffe. Now, in UK, in the last 30 years, statistics show that the breast cancer has increased 80%. 1 in 3 is breast cancer from all the cancers, other type cancers. 1 in 3. You hear the number, the incidence of 1 in 8 women develop breast cancer. That it should be more clear to you, saying that they don't die. Yeah, they might get the breast cancer, but that does not mean that they will die, because they can be treated. So 1 per 8 shows just the possibility that the woman has to develop in the population breast cancer. Now, it's more than this number you saw there, 50,000 new diagnoses per year. And indeed, the age that we impress us, breast cancer is a disease that is more found in young women, below the age of 35 years old. And they do have, in the age of 35 to 54, the death in that rate is not but because of breast cancer. Next slide, please. So it comes to the point where you ask, is this really an epidemic disease? Is it? What is it going here? The rate going up is really raising. Although our technologies, our studies, our money is hugely spent and indeed progressing, but it's still going on. And I bring another country, and we're talking about survivors, that as you hear in the previous talk, probably in 10 years we will know how many survivors will be in this country. In the USA, you will know now that there are about 2.5 million women who survive the breast cancer. Of course, it's a larger population, and the year the diagnosis is quite increased here, and as well as the rate of death. Next slide, please. Here is a simple picture of your anatomy. And what does it show? The gland with the lobules and the lactiferous ducts who bring the milk into the nipple, as well as the fat tissue around it. So the picture lower is how the cells come together and form a duct. Next slide, please. What happens with cancer? This picture here, I don't know if you can see it clear, illustrates clearly what actually happens with the breast cancer cells. And what does it show? Above, it shows how a normal breast cell survives. As we live all, the same the cells live as we do. They grow, they divide, they get old, and they die. Normally, the cycle of cell, normal cell, breast cell, is to grow, to divide, to get old, and die. It's called apoptosis, another word. What happens in cancer, there is some change in one of the cells, somewhere, and the breast cell takes a wrong way, a wrong pathway, which is out of normal, and what it does, it doesn't stop. It proliferates and proliferates and multiplies and multiplies, and it does not stop. Next slide, please. And here I put in simple words what I just said before. Okay? So what causes breast cancer? Do you know actually what causes that point for the cell to take a wrong way, a wrong pathway, and change everything? That process of that change of the route, the direction of the normal cell, we actually don't know. We do a lot of studies and a lot of biological studies analyzing our genes, but still we cannot trigger that point, because if we do, then do we stop the cancer? Next slide. Well, of course, we do know risk factors, and you hear them before in the previous talk. And I put them in groups. Genetic factors regarding family history, lifestyle, all you hear about, exercise, overweight, obesity, etc. But now is another factor here, which all of you should be aware. And what is it called? Environmental factors. And does not only cause breast cancer, but cause other cancers as well. So we come to the question, is genetics and lifestyle adequate to motivate that increased incidence of breast cancer? Next slide. If I stay a little bit, I'm not going to stay long in this slide. You hear it before. You hear about the family history, and you hear about the genes. If the family history, if one member is first degree, it's up to 6 times more to happen in the incidence in your family. If there are those genes that you hear before, that's much higher, up to 85%, and not only for breast cancer, but for ovarian cancer as well. In actual fact, those genes, breast cancer 1, breast cancer 2, they're not specific for breast because they have been found in other cancers, as pancreatic cancer as well. Now, in this one, you see rays there, and what does it mean? It is an important point. You are not going to stop on the age, you hear about that. Rays, what it means that breast cancer is more common in white ladies, but the black ladies die more from this breast cancer, and they get more aggressive breast cancer. About the reproductive and menstrual history, you hear about it. It's all about the hormones, children birth, breastfeeding, etc. Now, radiation exposure, you hear about it. And radiation is not only in the environment. You hear Mr. Chaffee refer to the bombs of Hiroshima. He said we don't have studies. Yes, we do, I totally agree. We have slight idea about radiation in treatments, different treatments for other cancers. Specifically when this radiation for a treatment on the lungs, on the breast, on the chest, then the incidence is noticed, we notice by studies, of course, a high incidence in breast cancer. Ladies who have a lymphoma and go for radiation, and most of them, they're young, they're advised to go ahead and have a surveillance mammography after a certain age, although they don't have a family history, so radiation is important. Dietary factors and lifestyle, you know all about it. Exercise, yes, exercise, what does it do? It just monitors the hormonal system. It does help to de-stress the body and helps to balance the hormonal system level. Next slide. Now, if I stay a little bit on hereditary, you hear a lot about it. This one shows that it's not only the known genes that we do know that can cause cancer. Yes, indeed they do, and they have a high incidence to cause cancer, but there are other genes as well. And those other genes can cause not only breast, but other cancers as well. Now, referring to the genes is a very interesting topic, because that will be the future in our medicine. And it will be a time where we all go to the GP, and what will it read? It will read our genes, so we have a genetic reading, and so we can manage to predict a little bit of future life of ours regarding health. But that will take a long time, and probably it's not going to be in my time as well. But that's where we will get at some point later in life. Next slide. Now that's the new group that I added for you here, because it's something we all have to consider, and it's a new alarming risk factor. It's called environmental. What does it mean, xenoestrogens? There are all these chemicals that simulate and come into the pathway of the hormones and disrupt the whole hormonal balance in your body and makes a mess. Does this cause breast cancer? Well, it can cause other cancers as well. We know that this one indeed can contribute, can increase the breast cancer, but also those ones, everything as I refer down below, pesticides, chemicals, dioxins, all can cause not only breast, but other cancers as well. Now, bisphenol A, those are all in plastic containers, and the factory that produces all these plastics materials and the industry provides and sells, they do have some chemicals that really disrupt the hormonal balance. The same, the fumes in the atmosphere. We don't know what we breathe. We don't know what we eat. We don't know what we drink. It's true, we all have to admit today. Dioxins, all the fumes, and it's absorbing the fat. And we can be affected from those, not only by just breathing, but also by eating animal fat, because that's where it's deposited. So all those we don't know precisely, but we have an idea, and it's all accepted now by the politicians. In Europe in 2004, I think, they well accepted the risk factors for cancer in the environment. Not only for breast, but for cancer. Okay? So, okay, divided in the groups, lifestyle and genetic factors can cause about 50% of them, but the other 50% is because of the environment. And we have detected, as you can see in this slide, it's a huge number of chemicals we know. And it's the paradox that I believe this is a good, it is a paradox today for the breast cancer, because you see very healthy individuals with a very healthy lifestyle, and all of a sudden they come up with the breast cancer. Where these come from? They have an organic diet, they are very healthy, they exercise, they don't have family history, and where these come from? So today is another question here. Is this really preventable or inevitable? So we do live in the genetically modified world. Unfortunately, you have to be aware of these risk factors. So do you do enough? Is it only for doctors to do their work? No. Every one of you and everyone around, it's their own interest. I know industries, they have a very huge fight. I mean, look at the cigarette, for instance. You hear about the risk factor, smoking, and the industries with selling the cigarette, non-stoppable. Even if you write down risk of health, that's still going on. It's all a move of industry to where profits and money. Politicians, they are more sensitive than industrialists, and as you hear, they start accepting the risk factors that they are in the environment. Now, before I go here, are you tired?
Yes.
You are? Who said yes? Okay, sir. Would you like to hear a joke, maybe? Okay, let me just say this joke to you, just for a break and a laugh, which I hear from a dear, dearest friend. My friend told me a joke, which is the following. So, our dear God sent one of his people down on earth with this advice: go down to earth and divide the people, the men, in two groups. Those who are obeying to my rules, and it's the head of the family, and those who are not the head of the family. So the person, the people of God goes down to earth, divides the men in two lines. In one line is huge crowd, in the other line is just one. In the line with the huge crowd, they're all the people that they don't do what God said to be the head of the family. In the other line, with a single man, is the group where they are the head of the family. So God looks at the crowd and says, what's going on here? It's only one side, only one person listened to me. So he goes and says, I have to go and find out, ask this person what happened. So God says to him, so congratulations, you obey my rules, you are the head of the family. How did you manage? I don't know, God, my wife told me to stand here. Thank you. Does it make any difference? Should I go on? Because you have a lot of things to hear there. If you're not up to, then we can go a little bit fast. Okay, let's go ahead. I'm not going to tire you with all of details, because you probably know what it means to symptoms and signs of a breast. You hear about awareness, you hear a lot of when you go to your doctor, they tell you, examine the breast, although clinical breast self-examination doesn't really help at all, and it's well documented, but we all raise your awareness, and the awareness is not relied upon, but be aware, know your family history. Yes, indeed, know your medical history, know what medication you are taking. If you're taking any hormones, discuss with your doctors. Have you been taking any hormones in the past? They're all important facts to know and be aware. Now, most of the cancers are detected with the lump in the breast. But also there are other signs that you, as a woman who knows herself, will be easy to pick up. There are little things, although pain is not a sign of breast cancer, but it should certainly raise your concern to go see your doctor and be examined by your doctor. Any changes in the shape of the breast, any color changes, any skin changes, nipple discharge. Is there any change in the nipple discharge? Don't worry if it's a yellow stick, but if it's a blood-stained discharge, it should raise the concern. Not all the lumps, although, are cancerous, but detecting a lump, it should direct you to see a specialist, to see a doctor, and have more investigations. This is a slide here which shows you the signs regarding skin, redness there, an inverted nipple, redness in the breast. Those are signs that really ring the bell. Go and see your doctor. These are easily underlying an inflammatory breast cancer. Inflammatory breast cancer is very confusing sometimes, because even your doctor can think, oh, with the antibiotics can go away. Well, if it doesn't go away, see your specialist, something is underneath it. Types of breast cancer. Now, breast cancer, there are a lot of types of it. When the breast tissue goes to the histopathologists, The information you can take is enormous. Even sometimes we detect new pictures that we don't know. So there are a lot of types of cancer. Most common, it's the ductal carcinoma, the invasive, and the invasive ductal carcinoma is the highest rate that we meet and we see diagnosed, as well as ductal carcinoma in situ. As you hear what it means, the early cancer. The lobular carcinoma in situ. And if you go down the list, you hear the mixed tumors. Those cancers that are both ductal, lobular carcinoma, invasive, non-invasive, inflammatory, which I refer to you. What it means, triple negative, another type of cancer. And triple negative, it all refers, as you will see later on, to those hormone receptors that they're not positive in this type of cancer. So none of the receptors is positive, so it's very difficult to treat, and it can have a bad prognosis. Paget disease, also, this can start as early with a redness or eczema around the nipple. Sometimes can present with an invasive, more advanced stage of breast cancer. So anything you need in change around the nipple areola area, talk about it with your doctor. This is a picture of how normal breast looks like with the ducts and the lobules. And what an invasive ductal, where it starts, and an invasive lobular carcinoma in the lobes. And how we diagnose? Where do we pick up those cancers? Two big groups. Symptomatic and non-symptomatic. Most of them, they are non-symptomatic. Symptomatic is rather less. And symptomatic means when you find something and you found it either yourself or you went to your doctor by incidental examination, found something in your breast.
Last year in Ecuador,
Yes. Yeah, non-symptomatic are all the women who are referred to the screening national health system. Okay, so that's why I don't refer to it I don't put many details, but the screening, as you hear earlier, you hear a lot, and the main first talk was about screening. Starts from the age 47 to 73, and that was established in 2009 and well distributed in all the country in the medical centers. Now, nobody will say to you, we will not do a mammogram because you're above 73. If you ever notice anything, talk with your doctor. Now, the screening, what you hear early, the screening involves from taking your medical history and knowing your medical problems, taking your family history, and then, of course, organize the imaging with the mammogram, ultrasound, MRI selectively. MRI is, as you hear early, is an image which is in details and very useful in cases that we are not sure or inconclusive. And of course, is well surveilled, well established, it's more or less accepted now for the high-risk family history, especially for the family history with the presence of the genes, the high-risk genes. Now, this is after we've done all the tests, the imaging. I'm sure some of you here have experience of that. biopsy, needle biopsy. So this is a very illustrative picture of a needle biopsy on a lump in the breast. Next slide, please. All the work for you involves more than one doctor. The moment you come to us, and we suspect that there is an area of concern in your breast, this involves more people. It's the more doctors, it's the multidisciplinary team, as we call it. And involves from the beginning, from the start, and the degree of involvement depends on the steps of treatment. The biopsy, as I said, the needle biopsy for the breast cancer is the core biopsy, which is larger than the simple needle you know. And this is what we prefer, and we want all the diagnosed cancers to have a core biopsy where what it does, it takes a little large piece of breast, of the tumor, from the chains where we already detected in the imaging. And this can be guided. Guided means that with the help of an ultrasound, the help of the mammogram, the help of magnetic resonance imaging, can direct us exactly to the site where this change is noticed in the image, so we can take that little piece of tissue and get the information we need. Some of those biopsies can be called vacuum biopsies, and those can be therapeutic, and it's in the very early changes, in very small early changes, that are noticed in a mammogram or in another image. Now, the results of this test will determine further investigations and staging, clinical or not, at later on step. Okay? Now, when we take that piece of tissue from the breast cancer lump or from the area of concern in the breast, with the first test, before even with your first visit, we have some information what change happens. We don't have the full information to organize the treatment because that will follow after, but we have some very good information to start with, and of course we have a clear view that yes, this is a cancer or not. And also, not only we organize the type of breast cancer, is that a ductal carcinoma, is it a lobular carcinoma, is it an early in situ, is it an invasive carcinoma, or any other type that we might find, and as you notice early. Now, at the same time, this early test of histopathology, of the pathologies, will come and tell not only the type, but also the grade. And what grade, you probably hear what grade means. It means those cells that deviate and take another route and go and become cancer, at what stage? Are they early, just about changing? Are they very well changed? Or where they stand? And is that important? Yes, it's hugely important, because that will organize and tailor the treatment that is needed for the diagnosis. Now, the receptors, what are those? As you all know, estrogens is one risk factor. So we need to block these estrogens, because if we don't block the estrogens, the cancer will grow. The same, the human epidermal growth factor, which is a protein, sits on the breast tumor, on the cancer. And if it exists, what it does, it progresses again. So today we can hit on that protein, we can block that protein, and those are target treatment. So it can stop the growth of the tumor and the spread as well. But not only that, probably future relapse. The later information about staging and genetic testing, as you see there, this is more detailed after your first step of treatment, which is surgery. After surgical treatment, and when the biopsy and the lesion is excised completely, then we can take more detailed information about the type, and the grade is precisely determined, as well as the stage, what it means, the invasive size of the tumor, the lymph nodes that can be involved, and is anything more invasive more than just localized disease? Is the disease spread farther or not? Next stage. If I go back to these slides about the genes that you see there, what it means, as I mentioned before, this is another achievement in our research and in our progress in breast surgery, because it's the future, as I said, in cancer, not only in breast, but in cancer, where we'll help to organize more specific treatments. And even confidently can say, yes, we treat today cancer, we will be able to do more. Okay? Now, the treatments, the step of treatments, as you all know, the first treatment we prefer is to excise the lesion, so it's the surgical treatment. But what surgery will involve is all organized by the previous information we had. Is an early cancer or is an invasive cancer? If it's a cancer that stays only in the cells and it has not spread beyond, then we will debate, we stay only excising the cancerous area, the area of concern, the area with the change, and will not do any other surgical procedure. Now, sometimes this group of people, they go back and have more surgery, and when that happens is when the result of histopathology is, because the exact information you take after you have the analysis of histology after surgery, where you know precise information. So if that information tells us that yes, it looked early in the core biopsy, but now it shows a high-grade change of the breast cells, on the breast cells. If that shows, then we determine to do the sentinel lymph node biopsy and determine if the cancer has spread beyond the breast or stays on the breast. So yes, in early cancer, selected cases don't go not only for excision of the lung, but also for the testing of the lymph nodes. Now, the invasive tumors, all of them, they go for lymph node testing. And again, those ladies who the lymph nodes involvement shows is positive, then they go and have further axillary surgery as clearance. Okay, now, what follows after surgical treatment, we got all this information, we precisely now know what's the advanced stage of this cancer we got, in what stage it is. What treatments we need to follow, it's all determined after surgery. And the treatment, some they will go for radiation therapy, some will follow chemotherapy and targeted therapies. As targeted, as I mentioned, is monoclonal antibodies when the cancer shows HER2 epidermal growth factor 2 receptors positive. Because if we leave them untreated, the cancer will progress, not only, but it will relapse. Now, taking the prophylactic mastectomy, I put that down there because, yes, as you hear before, there are certain cases, although they have not been diagnosed with cancer, the decision is supported for prophylactic mastectomy. But it means, specifically for this group of ladies with the breast cancer genes 1 and 2, who have high risk of breast but also ovarian cancer, the risk they have to develop breast cancer if the gene, breast cancer gene 1 is detected in them is about 85%. What does it mean? It's very high. 100 women with this gene, breast cancer 1, from 100 women with the breast cancer gene 1, the 85 women will develop breast cancer. This is a huge number. Yeah. Yeah.
Of the women who develop breast cancer, those women who carry the BRCA2 genes, is their cancer more aggressive than the general population without those genes?
Indeed. If it's left behind, it will get more aggressive and they die. They don't have any survival at all. I mean, a very small rate of survival. That's why we support their decision, and it's also an alternative, another treatment that we offer if we come across with cases like that. And if that happens, the incidence drops to 9. They raise the incidence of survival now in 95%, almost 100%. So it goes up to the general population, healthy women with no genes, rate incidence of cancer. Now, reconstruction that involves for all women who go under surgery, they have the right to be informed and decide about the reconstructive procedure that they want to follow. That's sitting between the doctor, the surgeon, and the lady to inform about the procedures of reconstruction and see what is appropriate, because in some cases it's more difficult and it cannot be done straight away at the same time they have the breast cancer excised. So they have to decide to have the reconstruction done at a later stage. Now, the reconstructive procedures nowadays, it doesn't involve only extensive surgery that you probably hear with the tissue move from one part of the body to the other. In some cases, we just deposit the fat tissue of your body into the breast just to reshape. As you saw early, the breast normally is shaped by the fat tissue in it. So we go back nowadays and we can reshape this defect that surgery caused with filling up with fat tissue inside the breast. So there are less dramatic reconstructive procedures. But all depends on the case, and it has to be decided according to every case diagnosed and every surgical procedure performed. Next slide. Prognosis. Everyone wants to know what's going to happen once a diagnosis has been done. How long are they going to live? I mean, the first thing you hear, am I going to die, doctor? How long do I have of life left behind? Well, this is where it's dramatic changes happen nowadays. Breast cancer is not like it was 30 years ago, it's not like it was 10 years ago, and it's not like it was 5 years ago. The treatments have progressed, so it's a treatable disease. And we can prognose with specific markers and tools that we do have. And as you can see, this is a tool which is called Nottingham Prognostic Index. And your doctor uses that index when you put that question on the desk. And according to this index, what it takes, it applies though only for the invasive cancer. It does not apply for a non-invasive, for the early cancer, because it's a very high rate of survival. So you're not interested to knowing there. You know already that you are almost treated, 95%.
5 minutes.
5 minutes. Okay. Next slide. The prognosis, as I said before, yes, the previous index and the previous tool takes histological factors. There are other factors that you can add to prognose and tell and make a final prognosis. And there are other tools that also the oncologist uses in to give a precise benefit of any treatments that is added on the treatments added in the breast cancer. Okay? So they are biological, as I said, biological refer to the genes. We look at the genes of the breast cancer and determine what are the changes. There are some of them, they dictate high risk. So what does it mean? High risk of what? High risk of recurrence in future and also less rate of survival. Now, we come in another subject. Before I go ahead, would I stop here and ask you to give me questions that you probably raised by this subject already here? Any questions, in other words?
When you have the estrogen-related cancer, what sort of hormone treatment do you give if you're negative?
Okay. First of all, the group of estrogen receptor positive has a good prognosis and has alternatives or treatments. Depends on the age. If it's a pre-menopausal, if it's a young lady who still has periods, then it's well in trials documented the benefit of tamoxifen. If it's a lady who is postmenopausal, we take the inhibitors, estrogen inhibitors, aromatase inhibitors as we call it. And those are medications that block the production of estrogens that are produced in the later life. So it blocks the effect, the presence of the estrogenic effect on the tumor.
Πολύ ενδιαφέρουσα το σεμινάριο απόψε, η παρουσίαση αυτού του θέματος.
Είχε ενδιαφέρον και για τους άνδρες, που θα ήταν ενδιαφέρον επίσης, γιατί ο καρκίνος του μαστού επηρεάζει και τους άνδρες.
Ένας στους 1.003 άνδρες.
Ένας στους 1.003 ή αλλιώς που το λένε εδώ στην Αγγλία, λένε ότι 3%. Στους ολικούς καρκίνους μαστού. Σε όλους τους καρκίνους του μαστού.
Το γεγονός ότι ήταν το Hellenic TV εδώ και σύντομα θα είναι και στο YouTube, νομίζω πολύ περισσότεροι άντρες θα το ακούσουν αυτό, θα το δουν όταν το προβληθεί από το Hellenic TV και στο YouTube, έτσι, και το γεγονός ότι το αναφέρατε απόψε, έστω και αν εν μέρει το αγγίξατε.
Ναι. Επίσης ένα θέμα που δεν πρόλαβα να αναφέρω είναι το ψυχολογικό μέρος με τη διάγνωση του καρκίνου.
Ίσως αυτό να χρειαστεί ακόμα ένα σεμινάριο.
Σίγουρα είναι πολύ ενδιαφέρον. Πιστεύω ότι αφορά όλες τις γυναίκες, γιατί ακόμα υπάρχει αυτός ο πανικός στην λέξη καρκίνος.
Κρατήσατε την προσοχή του κοινού σχεδόν για 2-2,5 ώρες, τόσο εσείς όσο και ο δόκτωρ Jeff.
Oh, thank you very much. Thank you for having me here. It was a privilege to me. It's my pleasure.
It was a privilege to have you and also Mr. Jeff along, and thank you for spending such an evening with us. As I told people, these are real issues, and Halloween can be celebrated at any time. Events such as these are very rare and very far between to come by. And I think people should make every attempt to attend this.
Yes, your efforts are really.
Αξιολογούμε που λέμε.
Είναι πολύ σημαντικό αυτό το έργο που κάνετε και με πολύ ευχαρίστηση μπορώ να σας μιλήσω και στα ελληνικά οποιαδήποτε στιγμή θέλετε, σε κοινό που το ενδιαφέρει μόνο η ελληνική γλώσσα. Με ευχαρίστηση μπορώ να λάβω μέρος. Αυτό
θα είναι για κοινών που θα είναι όλων ελληνόφωνες. Ήταν ένα μειχτό ακροατήριο απόψε. Το γεγονός ότι ήρθε ο κόσμος είναι ευχάριστο και ο Σύνδεσμος Λευκαριτών θα συνεχίσει να προβάλλει θέματα υγείας και όχι μόνο, τόσο στην παροικία όσο και σε όλων των κοινών εξ ολοκλήρου.
Αυτό είναι, παρακαλώ, και εγώ σας ευχαριστώ.
Σας εύχομαι καλό μήνα και δεν σας ζούμε χρόνια πολλά, καλά Χριστούγεννα.
Επίσης, ευχαριστώ, αλλά ελπίζω να ξαναβρεθούμε.
Μέχρι τώρα, ποιος ξέρει.
Να είστε καλά. Ευχαριστώ πολύ. Ευχαριστώ.